Have you signed? Yeah. I don't think they. I don't know.
The attendance sheet going around? Yeah. Thanks. Oh. Yeah. No.
Well, I saw your and I was going to email you anyway, just to see, but what day and time is like best for you?
I don't have a best time or day because my days differ, and so that's why I need to be, if you can email me and we can work out a time that's best for both of us, that'll be great.
Okay.
1 o'clock, okay, time to start. And everybody okay with the lights on? It's a dark day, and it's really very dark when I first came into the room, so that'll be good. Otherwise, yeah, I know. Exactly. I'm surprised. If anyone's going to do that, I'm going to do that. Yes, our regular reminder, speak loudly and clearly for our colleagues and for those of you that took this session for yourself. And we had one of those great chapters where there were only 4 pages. That was fun to get through the chapter very quickly. It was a review, and I hope that all of you found the table, nice concise table with all the information in one place. That's very helpful. And that started off with the comparison of 2 of our major analytic studies for epidemiology, the case control, and I put in parentheses case comparison. Sometimes they are called case comparison or case control. Either one is correct. Either one is appropriate. And so if you come across those 2 names, or titles, you'll know what is being referred to. And then the cohort study design. Actually, that reminds me of a question that I received this week in terms of there was confusion about what does an unmatched odds ratio, how is that calculated? I'm not sure if anyone, if we reviewed that yet. And that was a good question because we don't usually refer to it as an unmatched odds ratio. We just say an odds ratio. And so I believe maybe one of the questions in the text asked for the calculation of an unmatched odds ratio. And so that just means the odds ratio that we've been discussing. So odds ratio, odds ratio, unmatched odds ratio versus the matched odds ratio. So before we start, any questions, concerns, issues? Busy time of the semester. I just got out of a presentation by Dr. Heyer, who was had the Leading Voices presentation last evening. I wasn't able to go last evening. I was coming back from an NIH study section, and he was presenting to a smaller group this afternoon, and he was saying, okay, when you're doing crisis communication, remember folks are under stress, and when you're under stress, you can't remember anything that folks are trying to inform you with, or you remember things at a much lower grade level. And so try to get out of that stress situation. And it just reminded me in terms of dealing with family members who are in the hospital. I remember always sort of coming back home and saying, oh my God, I just dealt with that situation as if I was a third grader. I couldn't think. So important in terms of getting our points across in a matter of 9 words, 27 words in 9 seconds are best for the points that you want to get across. And also that your audience is going to remember what they hear first, what they hear last, and they'll forget everything in the middle. And so that made me feel really good about coming into this 3-hour session going, oh dear, I hope it's not as bad as that. But anyway, epidemiologic studies can be categorized how? How can we categorize epidemiologic studies? Experimental or observational, that's one way to categorize them. Any other ways to categorize epidemiologic studies?
Descriptive or analytical.
Speak up, didn't hear you.
Descriptive or analytical.
Okay, analytical or?
Descriptive.
Descriptive, very good, very good. Anything else come to mind? Go ahead. Sure. Then we can categorize them by study design. We have different study designs. Okay. The investigator controls whether a subject is exposed in what type of an epidemiologic study? Experimental, yes. And we have to put quotation marks around controls because it's very difficult to control a human subject, okay? Human subjects will often do what they want to do rather than what they've been told to do. And so then we get into those issues of a study subject not adhering to a medication that they've been randomized to. And so that then might create some bias, some washout in the results that we have. But if a study subject is not adherent to the medications to which they were randomized, do we drop them from the study? No, we really don't want to drop them. We need to what type of analysis should we use, should we follow when we're doing a randomized controlled trial to two groups? Intention to treat. Intention to treat. And so that is how we can continue to maintain control over study subjects. Okay, when the investigator does not have control over which subjects are exposed, smoker or not, given as an example, what type of epidemiologic study would that be? Observational. And what are the specific types of studies that are categorized under the label of observational? Cohort, case control, cross-sectional, sure, ecologic, and so most of the study designs that we use in epidemiology are observational. Here's all your answer. Once again, experimental, observational. We haven't spent much time on community trials. Those are quite powerful when we are able to use an intervention that is applied to an entire population. We might think of it as our population at the county level, and let's say that we had an intervention in which we were trying to obtain a fairly high level of vaccination rate for flu in Washington County. We may be using the media in terms of billboards, radio stations, getting pharmacies involved, grocery stores, whatever, just sort of this mass communication of get your flu shot, get your flu shot, get your flu shot. We target it onto a population versus having specific study subjects that are enrolled into a study. And then we would need some sort of comparison. How would we find a comparison population, or what would be an appropriate comparison population?
A community with similar demographics, maybe staying similar geographic location without that mass communication.
Certainly, certainly. We want to make sure that everything is the same except for the intervention. And what we really would like to do is have several counties that are similar, and then have the ability to randomize some counties to the intervention. Some counties would just be standard of care. They would not receive the intervention. So community trial, you think of it in terms of the same as a randomized clinical trial that randomizes individuals to group 1 or group 2. Now you are randomizing the entire community. One of the issues that comes into the community trials or classroom trials or randomizing schools or any entity is that each county counts as one. You may have 40,000 people within a county, your unit of observation is 1 for the county. And so you get into these sample size and power issues that are potentially difficult to overcome at some points. And remember, once you have a study design, you need to follow with a plan of analysis that matches your study design. And so you now have a community trial, you've got, maybe sample size of 4, but you want to get some information about the individuals that are within the community. Then you need to follow up with some type of what is called a hierarchical analysis and nested analysis. It gets more complicated and more sophisticated than what we're going to get into during this class here. And one of the reasons why there's not much time information on the community trials, because they can be very complex in terms of being a robust epidemiologic study. It's got lists of our observational study designs, which you all categorized correctly. And then for those that are into ranking, here we have a validity ranking for epidemiologic studies, and experimental studies are at the top of our highest validity. However, they're often not possible to do because of human subjects' ethical issues. One cannot expose human subjects to exposures, drugs, medications, whatever it may be, that we know will cause or potentially could cause harm to human subjects. And so in terms of our reliance upon high validity epidemiology studies, we're often dealing with what we are learning from large prospective cohort studies. And many of the studies that are reviewed by the Preventive Services Task Force are often those large prospective cohort studies. And as I was reviewing the materials for today's class, it was neat to come across one of the news items that you folks had brought up last week or the week before in terms of the new information on breast cancer screening. That all of that information came down from the U.S. Preventive Services Task Force. And so hopefully you're seeing that the information that you're reviewing in this class or learning for the first time is relevant to what you read, what you hear, and hopefully makes the materials more interesting. Any questions about this table here? We've got entered here time series analysis in terms of whether or not that's study design or analysis. We often use time series analysis in a prospective cohort study, but there may be sometimes where it's where it can be a standalone. A case study is that it is a description of a case, a single patient. They often make the literature because they are unique. It's something that the medical or health field has not dealt with before, and so wants to get it into the literature quickly so that others can reflect on the case study and say, oh, we just had a patient or a client like that come into our venue. Let's see if we can put that information together and see if it's potentially a cluster or something that should be studied further. Okay. So, to your knowledge, what's the main difference between cohort studies and case control studies? The population that you start with, correct. And so what population do you start with in a case control study? Okay, I've heard a lot at once, so I'm going to say it's the disease population, disease or non-disease. Okay, you're starting at the disease, and so what does that mean if you're starting at the disease?
With the cohort and
case control. I'm sorry. Am I jumping back and forth on you folks and confusing all of you? Okay. I started with I'm going out of order. I decided to start with the case control study. Case control study, we're starting with the disease. And what does that mean? If I start with disease, can I study any other disease? Okay. It forces us to study only one disease per case control study, okay? Because of the fact that you are starting with the disease and the non-disease population, that's all you can study. But since you're going back in time, you can look at multiple exposures. Okay. Cohort study, you're starting with what population? Exposed. And you can also think about it as starting with a healthy population, okay? Nobody has the outcome that you're interested in. So either way, it just depends what your research question is, what's the best approach. If you're, you have a very specific population, such as an occupational population, most likely you're able to say, okay, here's those that are exposed, those that aren't exposed. Sometimes when we start a cohort study, we don't know who's exposed and who's not exposed. Go ahead. Yes.
Weren't you describing some cohort studies that started like right after birth too? So the whole group might not have exposure to anything yet. That's right. And so it's the population that doesn't have the outcome yet that we're interested in. And so, as we were saying, you can, if it's an occupational cohort, you may know. Okay, exposed, not exposed. But for a great example, birth cohort, healthy live births, and you want to follow them up just to see what they might be exposed to during their life course. That's another way to describe a cohort study. Okay, so you've got exposed and non-exposed persons are compared for differences in rates of disease, or once again, starting with a fresh group of individuals that are naturally fall in one group or another. Okay, the investigator has no control over what happens as you look at the natural history of disease in a birth cohort, the natural history of an outcome from a birth cohort. It just happens. We observe what happens. We evaluate the information and say that A is associated with an outcome, collect that information, go to the next step and say, okay, is that association real? Does it cause the outcome? Case control studies, you have persons with disease and without disease, and they're compared for the portions who have the exposure of interest. What type of measure can be calculated for a cohort study? You have a relative risk, and what information is needed to calculate the relative risk? Incidence. Okay, your incidence of your outcome in the exposed over the incidence of the outcome in the non-exposed. Okay. So a lot of these calculations and formulas, they were presented initially as almost not having any context. Okay, I know how to calculate this, but how do I use it and why? Okay, so now we're getting to the fun part, learning how these measures of disease are useful to us, how they're meaningful, how we can explain to others what an incidence rate is, and if you put two incidence rates together, you can calculate a relative risk, and you can learn that you know, the exposed population has twofold increased risk of an outcome, and help folks understand what we learn in the newspaper or on the news. And for the case control study, we can also calculate measures of association risk. What do we do? Odds ratio. And as we're talking about relative risk and odds ratio, in your mind, you should be thinking about a 2-by-2 table, right? A, B, C, D, and how all of the study subjects they belong in one of those 4 boxes, and that can be used to easily calculate relative risk and odds ratio. For those that find figures helpful, another way to think about cohort studies and case control studies, cohort study on the top, groups that are compared, you're exposed, you're non-exposed, and the type of information that is collated at the end of the study, the incidence rates for the disease or the outcome in the exposed and the non-exposed. With a very similar diagram for a case control study, and so you can take a look at the left side of the figure, and it shows you the type of individuals or the groups that you start with. And then the right side of the figure informs you about the type of analysis that's conducted at the end of the study. Another way of using a diagram to conceptualize a cohort study. Here, it's demonstrating that multiple outcomes can be investigated using a cohort study, whereas with a case control study, since you're starting with your outcomes, since you're starting with your disease, it's only one disease or one outcome that can be studied. And so if you were asked strengths and weaknesses of a cohort study, or advantages, disadvantages of a cohort study. You might want to mention that you can investigate multiple outcomes with that study design. That's a strength of that study design. That is an advantage of the study design, and a reason for selecting that study design, in some cases, dependent upon what's your research question, what's your hypothesis. There we go. Advantages and disadvantages. Cohort studies. What are some of the advantages of cohort studies? With a cohort study, you can calculate incidence. And if you can calculate incidence, then you can continue on the continuum of calculating a relative risk. We've just learned that you can investigate multiple outcomes. So usually we like to ask for at least 3 advantages. And, okay, gang, here's a tip. Let's say you were taking an exam and you were asked to name 3 advantages, 3 disadvantages of a cohort study. Tip number 1. You will increase your chance of getting that question correct if you put down 4 advantages and 4 disadvantages, okay? So put as many as you have time to, and don't get fixated on that and keep going and going and going, but it increases your risk, because we look at that list, and if we can sort of pick out, okay, 3, then you'll get that answer correct. So there you go. There's your helpful hint of the day, which some of you already knew, and some didn't use. Okay, disadvantages. Yes.
Or question,
Yeah.
advantage. It says here that cohort studies are desirable when the exposure of interest is rare. But if you're studying rare disease, you would use the case control.
That's correct.
But the exposure, if it's rare, this would be advantage.
Correct.
Another.
Yes. There you go. Right. Another advantage. Right. Thank you. And thank you for contrasting that with rare outcomes. You go the other way with the case control study. And so think through that. Tell me, if the outcome is rare, why do you choose a case control study?
Because the sample size would need to be too big for cohort.
Okay. And why? Give us more of your logic.
Just because if it's a rare disease, you need a huge group of people to be able to have enough to study it, in a population. But for case control, if you're just looking at people who already have that disease, you can sort of chase things back. Right.
It's all in the definition. It's rare. It doesn't happen every day. It's rare, and so for it to happen, it's going to take a longer time. It's not saying that you can't use the study design, but it's not an effective, efficient way to look at rare diseases. The investigator would start the study, and he or she would not still be in the business of that study, would have to hand it down to their colleagues. And so, we want to make sure we're cognizant of our resources. Often our studies are funded by the federal government, and so as we write applications and submit it to funding organizations, one of the big things for us to stress is how we are using the funds wisely to answer our questions. And there's a question here.
Oh, yeah, sorry, I don't mean to.
No, please do.
Make sure I understand, because
please, yes.
I understand about case control desirable for rare diseases. I understand that and why that wouldn't work for a cohort study because they need a larger larger amount of people. But I don't understand how it's desirable for rare exposures.
Okay. Okay. Who would like to discuss that logic? Yes.
So in a case control study, you're starting with people who are diseased and people who aren't, but you kind of backtrack from that point to find out whether or not they've been exposed. If it's a rare exposure, then there's a good chance that there are very small numbers of people who are exposed. But if you're starting out with the design to look for exposure, then that will increase.
It's a similar logic, yes. Something is rare, and so you start with that rare, whether it be an outcome or an exposure. It's efficient, effective. It allows you to answer your question. Okay, let's see. We'll quickly go through these. You can calculate your incidence and relative risk. Okay, we didn't discuss biases much because we haven't gotten to that chapter yet, and I step over into that zone next week. But you do understand recall bias. There are, oh gosh, there's a very, very old article. I can't remember when it was published, but it was sort of like the 200 biases that can disrupt an epidemiologic study. And so there was a time when folks were fixated on naming every single bias that could occur along the way. Now we've sort of categorized them so that everything doesn't have a name. Desirable for rare exposures. Likely to have better data on temporal relationship. And, you know, I hope that shows up on your list because that's really the crux. That's the reason why we are using the cohort study. It really provides us with good, hard, strong, robust data on the temporal relationship of what we're investigating. We've learned that there's an association sometimes through a cross-sectional study, but, you know, an association, but, you know, what came before? You're conducting a prospective cohort study, you can document that temporal, that time relationship, what came first. Yeah, cohort studies, even though we might have a very specific research question, they usually do require large populations. Very difficult to get funded. We are at the point of time where we're seeing fewer and fewer cohort studies started versus taking advantage of those cohort studies that have already started, that we've collected data, that we've got banked data, whether that be banked questionnaire data, banked medical record data, banked specimen or tissue data. If the, and usually, at least in the United States, our large cohort studies have been funded by National Institutes of Health, and so National Institutes of Health is the repository of all of these data, and we should always, before we start a new study, make sure that the data don't already exist. Okay, we've already paid for all of these studies, all of us as taxpayers, and so we need to first determine if, is questionnaire data available, or are there specimens that we can then take out of that bank and use. There are most often newer techniques that can be used to study the tissues, the blood specimens, whatever. And so a lot of that is being done. I'm thinking about an announcement that came out from NIH last week in terms of, I have mentioned the National Children's Study previously. It was determined that study was going to cost too much, stopped. And so after advice from experts, public comment, we've now learned that what NIH is going to redirect that study so that extant cohorts are used, existing cohorts are used to ask the very 4 specific outcome questions regarding children in the United States. But once again, it's almost like, you know, the recycling thing, reuse. Don't go out there and collect new data if you don't have to. Reuse what has already been collected. Sometimes it works, sometimes it doesn't work. Okay, disadvantages in general are expensive to carry out, yes. Greater potential for bias assessing the outcome. Greater potential bias for assessing the outcome. And I tend to disagree with statements like this only because I like to approach it the other way. Just try very hard not to allow bias to enter your study design, meaning that you have to design your studies so that they are reliable and valid, and try to think about all the potential biases that could occur. Yes?
I have a question. I haven't taken biostatistics yet, so I'm not sure if this is what I'm thinking is related to this at all, but if you have a larger population, does that inherently mean that there's a bigger risk for error or bias when you're, you know, assessing the data at the end? Or does it really just have to do with the quality of your design before you start, or is it both? Because if you have a bigger population for cohort and you might for case control, is there inherently like a bigger risk for?
Okay, and you tell me if I'm addressing your question. Bigger does not mean better. Okay. What you are aiming for in a cohort study is what is the necessary sample size that you need, okay? Don't make your study any bigger than what it needs to be. I see that as almost an ethical question. Don't ask a human subject to participate in a study if you do not need them, okay? So design your study appropriately so that you have the necessary number of participants that will allow you to answer your research question. I think that may address part of your question. What was sort of the second part of your question?
Statistically, if there's a higher risk for error if you have more people involved in the study? Or if it just really depends on the quality of the design.
Okay, and you have a higher risk for error for other reasons, and it's not statistical reasons.
Okay.
Okay, and so you may not be appropriately staffed. So you have staff going out trying to collect data, and they know that they have to do, oh my God, now I have to do 20 interviews a day, and I don't have enough time to do that, and they do it quickly, and they do it incorrectly, or, you know, they're not trained properly, and so it's that whole thing of whenever you try to do too much, what happens? Quality goes down. And so That's more. Okay, and we all know not a good study for rare diseases. These are fun, these arrows. All right, case control study, a similar figure in terms of you can only study one outcome, one disease, but multiple exposures. We have a hybrid design that's called a nested case control design, and it's really quite fun. And you have, as your cohort study goes forward, cases can begin to drop out of your cohort. And so that's why they call it nested. It's nested within a cohort study. Recall bias is eliminated because data on exposure is obtained before the disease develops. So you see that, you're collecting that information, or you're potentially collecting that information as your prospective study is going on, and you're obtaining that information about the individual before the individual gets tainted that they have the disease, okay? And so we often worry, the individual has been diagnosed with some sort of chronic disease, and then they're just racking their brain. Why me? How did this happen? What did I do that I now have this outcome, this disease? And so their thought about certain things are different from the comparison population, because the comparison population doesn't have the disease and is not putting themselves through that line of thinking. Exposure data more likely to become accurate because collected in a similar concept. Cost lower than for cohort study because laboratory tests done only on specimens and subjects who are later chosen as cases or controls, rather than your design may be just that, rather than doing laboratory tests on the entire cohort. Save it for the nested case control. Similar thing, advantages and disadvantages. What would you like to add to the list for advantages?
You don't need as large of a sample size.
Okay, yeah. And so remember, and you don't have to do this when you're taking an exam because it takes time, but as large of a sample size as what you need that
a cohort.
Okay. You need to sort of finish out that phrase, but understood when you're in a time crunch. Quick and inexpensive. No study is quick. It's quick, So, like I say, some of these things are relatively small number of subjects required, desirable for rare diseases. Disadvantages, they often require data about past events, often have problems with biases, including recall bias. When you are proposing a case control study, do your little pilot and make sure that what data you think exists actually exists. Sometimes folks, well, then I have to, complete an IRB, and I have to do this, and I have to do that. Believe me, if you do your work up front, that will cause you, or protect you from a lot of bad things that could happen at the end when you have a wonderful timetable and you're going to graduate, and then you realize, oh my God, the dates don't exist. Find out here. You can change your approach, change your question. selection of an appropriate control group may be very difficult, and that's one of the hardest, time-consuming part of developing a case control study is finding the appropriate control group. Cannot calculate disease incidence or direct risk. Correct. So that was our quick comparison of cohort and case control studies found in Chapter 13, the nice table, and Gordon in Chapter 13. You'll find that the slides that we just used and reviewed are duplicates of most of the slides that you've already looked at that are labeled slides for Chapter 13. And let's take a short break. And where's the clock? Do we have a clock in here anymore? Okay, no clock in here anymore. They're all wrong around here anyway. Right? It's 1:48. What time should we be ready?
2 o'clock.
2? Okay, sounds good. Let's be back in here at 2 o'clock. Thank you.
Girl, and she said, half a minute, what a tablet. It's really so hard. She's not trying to like raise my kids. That's what my parents did for my brothers. Like they bought them. I had a few brothers and they bought like a PlayStation. But I didn't have anything. I don't like playing with PlayStation. Hey! So, we're doing the same thing. Like, why are you doing today? I don't want to go to class today. He's like, go to class. I was like, no, I don't want to go to class. I was like, I want to. He's like, go. It's his fault. I should have said,
been so productive. I could have been doing laundry.
Why do you never
today?
I'm saying the back.
Could be different, right?
I agree. I know.
It's hurtful.
Come on, guys. It's just, can't focus anymore. Are we doing 2 lectures today? Yeah, 2 chapters. Oh, 2 chapters.
What room? We've already done this stuff, so I don't know why. I know you travel. So I might as well be productive and look at the
No, that's what I do. I'll go back.
Or invitations, or what am I supposed to dresses.
In March.
May.
Are you kidding me, you guys? Yeah, I'm
planning it.
Sorry.
I'm planning it. I didn't want to plan it, but I have to plan it. I'm really excited. The only thing that like makes me feel discouraged is when I think about having to like give out all my invitations because I've asked people for their address and I don't feel like doing that.
Oh.
And so my husband, he's been doing that. So that's been helping out a little bit. But I'm excited.
Are you done with the I'm missing.
I've had some dress, and they're going to like make some arrangements and stuff. I'll show you the dress.
Oh, it's right here. Really?
There you go. See, this is more crazy.
Yes. Sure. Tell him you'll go shooting with him. You know, it wasn't being crazy. You kidding me? You got started? I just and how much? British rock, you did that? Yes. I did that. Oh my God, I shouldn't be wasting my time. Like, I'm not doing anything. I'm not doing anything fun. I'm not doing anything productive. I'm not doing anything. How do you manage that? How do you get to the class? How to like take
That language is I was fun with you guys.
utilize your time. Time management.
I didn't even hear
My days, studying, get it all done. I don't know how you do it. I have no idea. Your mom, yeah, you do everything. You don't cut them. You see him. Yeah.
Oh, okay.
His name is Hamza. And he calls him
What's the difference?
Hamza and Hatta.
Is there a difference?
Like he cannot pronounce it.
Oh. So cute.
I sit down with Slimy every day. I should. I love the kids. Yeah, she was. But I think that, oh my God. I know, but I like to over it now. I'm in She doesn't actually. Oh, wait. These documents are going around now, and even before, but would perhaps give you a way to remember some of the issues regarding causation in a different way. I think during our third week, we did the exercise on causal inference, and it was sort of based on a fun story, and may or may not be helpful to you. Just wanted to remind you that this is information that you already have learned and discussed. We did this as a class exercise, and so you've got that copy, and I've also reposted it for week 10 if you wanted to review that. Remember, it was also associated with an article on television viewing and initiation of smoking among youth, where we were asking questions about whether television viewing was a cause of smoking among youth. And so you can find that article back at week 3. And then this very classic article from 1965 in terms of the Hill items associated at that time that were used for causation: strength, consistency, specificity, temporality, biologic gradient, plausibility, coherence,
an experiment, and it is, for those of you that are interested in history, all of our professions have a history, and it's often nice to sort of pause and see where we've come from and how our knowledge has increased, how technology has changed, the environment has changed, and so some of the ways in which we decipher things, think about things, have changed also. It's okay to change. We're always changing. We need to change. Anyway, those are two articles for your use, however you wish to use them. So here we are, now advancing our task in epidemiology and learning how to think about causation, because that is such an important item to discuss and get across. There are those that think that epidemiologists don't do their job well because they don't advocate for what they think are causal associations, things that they find in their own research, that once we do the statistical analysis and we place it into a manuscript and then we publish it in some obscure journal, that the lay individual would not go to the internet perhaps or to the library and start reading American Journal of Epidemiology, and that we, to be true to our profession, we should go a step further and bring our evidence to the public. Part of that is because of our training. We were never trained to do that. We're not very good with the press and the media, and we are often using our time to go on to the next question. And so sometimes, if you think about it the other way, the causation or the discussion of causation gets into the wrong hands, into the hands of individuals that don't understand how to think about causation, how to critically think about causation. What does causation mean? What questions should we ask before we say A causes B? And so chapter 14 is beginning to help you do some of that. And it can be very confusing. It can be very, very, very confusing. And so there are, chapter 14 begins to give you some of those tools that will help you frame questions about, you read something, you hear something, well, maybe I should ask about the strength of the association. What's the relative risk? Gosh, gee, confidence interval includes 1. Can I say that doesn't seem to match with what I'm learning in epidemiology? So let's see what we can learn about determining causes. Usually starts with an association or a perception that an exposure somehow is related to a disease, and we are trying to determine if it's a real association and whether it's a causal association. And so we have that question, always questioning, is the association, is it causal? Or or is it just an observation? We may start with animal studies. For some exposure outcome situations that we're testing, animal studies may be very, very appropriate and sometimes necessary. Drug development, vaccine development, those type of questions start preclinical with animal studies, or even, you know, the in vitro testing. It's the first step. That evidence is needed before you can put your application together to test the device, test the drug in human subjects. But the number one thing is animals are not humans, and as much as we can do in the animal system, it's not going to answer all the questions that we have about potential risks in our environment, what increases our risk, our chances for certain outcomes. And so we must rely on epidemiology. Okay. So that's why we need to make these observations in human populations. We make our observations through cross-sectional studies and case control studies and cohort studies. And as I mentioned previously, unfortunately, we cannot go to the top of that validity tree and just answer all of our questions with randomized controlled trials. And so we fall into natural experiments, groups that will allow us to retain temporal relationships if they so exist, groups that may have data collected on them that can help us to answer certain questions. Naturally exposed groups, because we don't want to unnaturally expose human subjects to certain things. And so as we saw the sequence of our studies climbing the validity ladder, here we top to bottom here, clinical observations, available data, case control studies, cohort studies, and then if we can, randomized trials. Okay. A two-step process that is being introduced to us. First, we determine whether or not there's an association. And we don't want to just see one study and then directly jump into testing whether or not it's causal. We want repeatability. Is this happening? You know, did we just somehow end up with some study population that is leading us to these results? We still don't know if the observation is true or if it's spurious. That's kind of a fun term, spurious. What does that mean? Spurious. I'm still listening. I'm still listening. Spurious.
Not genuine.
I'm sorry?
Not real.
Not real. Yeah, false.
False.
False. Yeah, spurious. Just like that word for some reason.
And so, yeah, the chance of being false. So we want to see when we learn from NPR that drinking 2 cups of coffee a day increases our risk of pancreatic cancer. We want to make sure that that statement is based on multiple studies. We want to ask, is that just an association? Are they informing us that it's a cause? Is it a true cause? Were those spurious results? Once we determine that it actually is an association, then the next question is it a causal association? And so why do we need to go further? If we learn that it's an association, who cares? Isn't that far enough? Why do we need to know if it actually causes the disease? It's associated.
There could be a different factor that causes it, like I think they talk in the book about the pancreatic cancer example and coffee drinkers, but the coffee drinkers, the majority of them were also cigarette smokers. So confounding?
Confounding? Sure. It's maybe something else. That factor is associated with another factor, and it's actually that factor that's the causal factor. And so we could be spending a lot of time, a lot of money on factor A, and it's really not getting to the causal issue. Okay, here we go. We have associations real associations, false associations, and we can get an association based on just really poorly designed studies. And so that's why it's so important to take the time and develop a good study. Think about potential biases that could occur. Think about measurement error. Make sure that you're using the best technology that you can, considering the resources that you have. Be willing to say, we cannot do the best study right now. Perhaps we need to call our colleagues down the road and do a multi-center study so that you're using the resources most effectively. A diagram of what was just mentioned in terms of a causal study characteristic is directly associated with the disease or indirectly associated with the disease. You see that in terms of these diagrams, what you're focusing in on are the arrows. Where are the arrows going, and are they going back and forth? Are they going in one direction? Do you see the tip of the arrow at both ends of the line? These are ways in which we document associations and whether or not they're causal associations. All of these figures are taken directly from the text. Just an opportunity to view them here, for you to ask questions about them if there's something that you don't understand when you read it and now we're talking about it. Is there something else that's confusing or you want more information on? And so here we have association between increased coffee drinking and an increased risk of pancreatic cancer. Both are observed associations, but as was stated, we have a factor now that is in the middle, and that's the smoking. So is it the coffee? Is it the smoking? Another example of increased cholesterol level an increased risk of coronary heart disease. Constantly asking, is it a direct association? Is it causal? Are there confounding factors that are somehow placing themselves in the middle of what's being purported as a causal association? And so this is the question that we were asking as we try to interpret real association. Is it important? What difference does it make? Well, it either makes a difference to the individual at the clinical level, or it makes a difference to the population in terms of the validity of public health programs. So we want to make sure that before we say that something causes an outcome, a disease, that we've questioned ourselves about, well, potential confounding, potential bias. We'll learn more next week about potential for interaction. It's also important to learn whether or not you have a direct or an indirect cause of disease. And as you've read, as you learn, it's really quite rare for a direct relationship in terms of a causal relationship factor in disease. We early on talked about the web of causation, meaning that it's not direct from A to B, but we have multiple things that are associated with the disease. There's the individual factors, an individual's genetic makeup, an individual's physiology, an individual's metabolism. Those could all be part of that web. Then you get outside of the individual, the environment, the different environmental factors that we're all exposed to from birth, prior to birth, social implications, and so that is why it's so difficult for us to deal with the major public health issues in the United States, for example. You talk to groups of individuals, you know, obesity comes up. And so that's the largest public health issue. That should be easy. Why can't we figure out how to curb the obesity epidemic? Can't we just tell people to, you know, be in a normal way? What's the problem? Why is it so hard? It's hard, right? It's hard. It's really hard. It sounds simple. It's hard. We really don't know. If we really knew what caused obesity in different populations, then we should be able to come up with an intervention that would get everybody back to normal weight, children, adults, animals. Animals have problems with their weight also. Anyway, because it's that web of causation, so difficult to come up with answers that now are really giving us the bang for the buck. It's hard, it's difficult. The world in which we live in is complex. New things are introduced to us. Our environment is changing. the chemicals in the air, what's in our water, what's in that dust that's, you know, all over us, different materials, clothing that we wear, clothing that children are exposed to. Remember, we used to be very concerned with children being exposed to bedding and pajamas that could burn quickly. That's an exposure. So we did something so that they wouldn't be exposed to materials that would catch fire quickly. What do? We put chemicals all over them. Well, we save them from one thing, we expose them to another. It's complex. And so that's why it's difficult to find out whether or not we've got direct or indirect causes, whether or not it's a true cause or a spurious cause. Direct, that's it. It's direct, A to B. Nothing in between, okay? Indirect, something else is happening. It could be something that, you know, these terms will come up later on in the semester. That middle factor could be additive, it could be multiplicative. We have to learn that too, because then in terms of our intervention would be different depending on what type of indirect causation we're talking about. So in human biology, we're not talking about the animals, because, you know, now that we can get any type of rat that we want that has only one, you know, gene influence and everything else is knocked out, can't do that with humans. In human biology, intermediate steps are virtually always present, in any causal process. This is consistent with the multi-causal nature of most disease, okay? Most diseases don't have a singular cause. Life is complex. Now here, we'll start talking about the 4 types of causal relationships. And for those of you who need a different way to think about what these 4 types of causal relationships are, go back to the causal inference article, and there's that fun way to learn about necessary and sufficient, necessary but not sufficient, sufficient but not necessary, neither sufficient nor necessary. And so, also, what can you do with those words? Oh, you don't think like I do. You can put them in a 2x2 table. Oh, yeah. Okay. So if you want to remember them that way, you can do it that way. It's like you know, remember when you're trying to put the match cases in control? Kind of similar to that. So we live in our very small world of 2x2 tables. Let's make sure. Okay. Okay, so just some words of wisdom from Ken Rothman and Sandra Greenland. As the types of causal relationships are considered from the perspective of necessary and sufficient, it's useful to define the term sufficient as used in this context. Sufficient is a set of minimal conditions and events that inevitably produce disease. Okay. A factor is both necessary and sufficient for producing the disease. Without the factor, the disease never develops. And in the presence of the factor, the disease always develops. The factor is sufficient, okay? Necessary and sufficient. It's necessary for the disease and sufficient. Doesn't need anything else, okay? It's necessary and sufficient. Usually doesn't very basic type of causation. You usually don't have one factor that causes disease. You know, think about the whole thing of cigarette smoking. It's not necessary and sufficient because if everybody that, in terms of causing lung cancer, everybody that smokes cigarettes does not end up being diagnosed with lung cancer. Even in infectious diseases, not everyone who is exposed to the causative agent will develop the infection. Okay, so it's one of those things that is going out of fad. A one-to-one relationship of exposure to disease, which is the consequence of necessary and sufficient relationship, rarely occurs. Okay, just it happens to be part of our 2x2 table, but it rarely occurs. Too easy. Necessary but not sufficient. Each factor is necessary but not sufficient to cause the disease. Thus, the disease cannot occur without the factor. However, each factor by itself is not adequate to cause the disease. And so if factor A was all that was needed to cause the disease, we would have an arrow from factor A to factor A to the disease. But that's not the case. Factor A needs factor B. Factor A needs factor C, just as factor C needs B, B needs A, B needs C. Okay, so you may have folks that are running around with factor A only. Okay. But just because they have factor A, and you know that factor A is somehow involved in this causal pathway, just focusing your attention on factor A is not good enough or wide enough to really have an influence on the incidence of disease. Okay? Put all your money in factor A, you're not necessarily going to have reduced incidence of disease. What you really should be doing is focusing on A, B, and C. Necessary but not sufficient. Multiple factors are required, and sometimes in a specific temporal sequence, a time sequence. Oh gosh, you have to have A first, then B, then C, then that makes things even more complicated. And so, yes.
Sorry, I just have a question.
Yeah.
Can time be one of the factors?
Can time be a factor? Sure. Mm-hmm. Yes. Yes. But tell us why you asked that question, and that's more for me to make sure. Here I am saying yes. Tell us why you asked that question. What are you thinking about?
I'm just thinking about different diseases that affects elderly people more, and so, for example, we don't look at younger people. We only look at people 60 or older for certain types of diseases. So I was thinking time. Okay, and so yes, in terms of time, but we would most likely think of that factor as age. Okay. Does that make sense? Yes. Okay, good.
So shingles would be an example, like kind of what she was saying, you'd have to have chicken pox and then you'd have to be exposed.
There you go. Excellent. I like that. That's a great example. Yes.
Does the order of the factors matter? Like if you have factor B before factor A, does that mess up?
Sometimes it does. Yes, exactly. Yes. There we go. Often in a specific temporal sequence. I knew I saw that somewhere. And when did we start our war on cancer? You're all too young. Yeah. I know. That tells me you're just all too young.
A long time ago, we were in the 60s, it was pronounced we were going to throw tons of money at cancer. We were going to find the cause, we were going to find the cure, we were going to win our war on cancer. We really haven't done very well. We have done very well on new technology, new diagnostic testing, screening, getting our populations in for screening. That's changed things a bit, but, you know, have we really gotten much further along with a war on cancer? Haven't, because it's difficult. Carcinogenesis is considered to be a multi-stage process involving both initiation and promotion, and here we go, back to here, occurring in a specific order. We're learning a lot more about this. It's not, you know, it's not black and white. Finding the cause is difficult. Sufficient but not necessary. A factor is sufficient but not necessary, thus the factor alone can produce the disease, but so can other factors acting either alone or in combination. So there may be multiple factors that can be involved in terms of causing the disease. A, B, C, or. You see that the important linking word here is or. Factor A could cause B or C.
Question?
Yes.
So, and I'm looking at the example like of radiation or benzene exposure,
Mm-hmm.
and I'm wondering, like, if a person is exposed to radiation, is that's necessary and sufficient for, like, cancer or radiation poisoning or something like that?
You're asking multiple questions. Radiation poisoning is different than cancer.
Right.
Okay. So,
but I'm saying, like, if you wanted to, because I know it says that it's necessary and sufficient is rare, but for something like being exposed to radioactive elements or I don't know, whatever.
Everybody exposed to radioactive elements doesn't get cancer. Does that answer your question?
Yes.
Okay. Sufficient but not necessary. As an benzene exposure might produce leukemia without the presence of the other. It's rare that a single factor will be sufficient as a cause. Yeah.
I just have a question about the last one. So, doesn't someone's individual genetic makeup always play a role in whether or not they will develop a disease? So, like you just said, exposure to radiation doesn't cause everyone to get cancer, and that's something pretty toxic and intense. So, if that's true, then the one
because remember, let's look, and I want you all to think about this. Exposure. You also need to define and operationalize exposure. Okay. So I don't want you to think that I'm saying something wrong. No, right.
No.
Yeah. No. But there's other things to think about. Yeah. I'm sorry. Go ahead.
No, that's okay. My question was for the slide we just saw where it's like individual factors could cause a disease. Doesn't someone's individual genetic makeup always play a role in that? So how would that fit into, or does it not?
It does. It does.
So is that just assumed?
It's a huge issue, and a issue that now has us throwing money at genetics, precision medicine,
which I know it makes me, I can't get my head around how that is helpful for population health, but that's just because I haven't gotten there yet, and I'm sure that it is. But yeah, genetics is very important. It can be a factor, and I'm not going to use an absolute term. Just got, like I said, I just got out of a presentation that basically said don't ever say never. Never. Don't ever say always, or don't ever say it's over. You never know what's going to happen tomorrow. So,
okay.
But yes, definitely a factor, important factor, and now is making our web even more complex.
Right. So in a model like this, we're just assuming like factor A. If factor A causes disease, it's really factor A plus somebody. That's what I'm asking about. It's like how to account for that in something. Like
Okay.
On the other slide, it made sense because one of the
Right. Can we now say there? Is there ever an example of genetic? Yeah. Let's think about the physical environment can cause an outcome that may have absolutely nothing to do with an individual's genetic makeup. Whether or not the elderly individual has, whatever you call those little rugs,
yeah.
in their home that can cause a factor that increases their risk for a fall. Okay. So yeah. So let's think broadly. We're in a college of public health, and I know many of the examples in the text, many examples that I use were, and thanks for bringing that up. That. We think a lot about disease. There are, public health is a huge profession. There's other things that we're concerned about. So thank you for that question, and that's good. Okay, neither sufficient nor necessary. The factor is by itself neither sufficient nor necessary to produce disease. Just can't do it by itself. You need something else. These are models, and this one, as states, probably presents most of the causal relationships that operate in chronic diseases. And the reason why we can't win that war on cancer. Multiple factors that have a very complex causal pathway in the development of disease. And just thinking about it is very, very complex. And so, once again, these slides are the slides that are within week 10 and are labeled as Chapter 14 slide. I'm not going to bring you through this timeline. I'm going to bring you through in a very quick fashion, sort of into the future. I cannot believe that 2015 is the are you folks familiar with that very old movie? No, you're not. You're all too young, but Into the Future movie with, who was in that? Yes, right. Where he's going into a time, right. He's going into this time capsule, and the time capsule was 2015. It was October something 2015, and just sort of like, oh my God, geez, I'm getting old. I can't handle this. But anyway, so now we're in the future.
Some of the things were correct. One of them was, I think, so 30 years into the future, and they said, well, in 2015 there would be the ability to have sort of phone conversations where you could see someone talking to you. They had the hoverboard and kind of have that. Some of the things we don't have. Sort of like, isn't that interesting? Okay, so we sort of start with conscious postulates, and this was working with knowledge at the time. Okay, and so we've become more sophisticated. We're changing the rules and the criteria for which we use to determine causality. So you become familiar with conscious postulates. Organism is always found with a disease. We can't. That's a term we can't use anymore. Always or never. Or it's always something that we could learn. Anyway, they're old. We don't really use them anymore. But it's sort of interesting to see how they've changed over time. Then we have the U.S. Surgeon General appointing an expert committee. This was really big in terms of what was happening with smoking and lung cancer. Look at that. The report published in 1964 listed 5 criteria: strength of association, time sequence, consistency upon repetition, and these are still very important in terms of looking at epidemiologic data. Specificity, you all know what specificity is, and coherence of explanation. If it doesn't make sense, it's probably not correct. Let's go back to logic. Oh, that doesn't make sense. Well, probably not. It happened once. It's a rare event. And then the article that we passed around again today in terms of now there are 9 rules of evidence. Many of them are associated with the 1964 5 criteria, temporal relationships, strength of association, dose response, whether or not you can replicate the findings, biologics, considerate of alternate explanations. And sort of this new thought creeping in, cessation of exposure, consistency, and specificity. Strengths, you'll see these are basically definitions of each of those. And then the most recent updates to these guidelines. And this is what our preventive services task force is using. I put on D2L in week 10 a URL that leads you to the vice chair, I believe, of the current committee as she describes the new statement from the task force regarding their breast cancer screening recommendations. And so that's a short little YouTube that's interesting to listen to and to hear about the decisions that they made, what they used to make those decisions and recommendations. So it's worth checking out and certainly applicable to what we're trying to learn here. Let me get to, there we go. And so this is the criteria used by the U.S. Preventive Services Task Force for grading the quality of the overall evidence. We can only use what we have, the data that's been collected, and good evidence includes consistent results, okay, sort of that repeatability, a term that's
being thread throughout the years. Well-designed, well-conducted studies. How do they determine if they're well-designed and well-conducted? They critique them. They critique the studies. They say, what are the strengths? What are the weaknesses? Were the methods appropriate? Was the analysis appropriate? Very similar to what you did with exercise 2. You were serving as if you were a member of this task force and you were critiquing the article to determine whether or not that article should become part of the pool of evidence that the task force then uses to make their recommendations. And so an exercise that is used, you know, at the level of U.S. Preventive Services. It's an important tool for you as you go forward in your profession. Fair evidence is sufficient. Poor evidence is insufficient. Anyway, a nice table to refer to. Go to their website and you will learn that they are continually making announcements. Most currently, what's today? Today's the 28th. Yesterday, they submitted or posted their final recommendation statement, screening for abnormal blood glucose and type 2 diabetes. 5 days ago, their final research plan for menopausal hormone therapy for the primary prevention of chronic conditions. And then on that same day, their final research plan for interventions to prevent falls in older adults. And then they also have an opportunity for public comments. They're informing you what they're going to be working on in the future, and they request input from the public. So quite informative to keep up with what the Preventive Services Task Force is doing. And they give grades. They strongly recommend, they make no recommendation, they recommend against, and also conclude that the evidence is insufficient. More research is needed. Sort of interesting. Okay, I think, yeah, okay, all right. Causal guidelines are often referred to as criteria. Okay, causal guidelines, criteria for determining if a cause exists. But very interesting. Often not enough is known about the disease to consider these guidelines as objective criteria. We just don't know enough. And these lists should be considered to be only guidelines. And that's all we can say. When the Preventive Task Force, they will say, you know, the recommendations, their guidelines, take them, review them, see if they meet the situation that you are trying to solve. So that's it. Like green, no more. Class is over. Questions? And actually, there was a question at the beginning of class. Right, I don't have standard office hours just because I can't. My days are not standard, unfortunately. Actually, that's kind of, I like that. So if you need to meet with me, I will meet with you, and I will meet with you at a time that's convenient for you, and just contact me. Say, I need to meet with you, we'll find a time, okay? Do that by, best thing to do is email. Great.
All right, thanks. Have a good week.